Hello everyone, I'm Dr. Sourabh Sharma. Let's discuss ophthalmology questions in the recent exam of INICET in November 2022. So there were two sessions, first time from INICET, one in the morning, one in the evening, and there were 16 questions in totality which students have told me might be 8 in the morning session and 8 in the evening session. And if you have revised well, according to my judgment, out of 8 questions in one session, I think you should have got 6 plus, correct? And if you have really revised well, almost all of them were doable. Let us see how. So there were 16 questions. Let us see one by one. The first question was a question which is discussed in the first session of my ophthalmology lecture on Snellen's chart in the basic physiology. The angle subtended by the 6x6 letter, that's the normal vision in Snellen's chart. That's the most common chart for visual acuity measurement based on the form sense. And the patient is standing at 6 meters. So you see Snellen's chart, the top letter is 6/60, the best vision, the normal vision is 6/6. Numerator is the distance from where the patient is standing and denominator is the distance from where a normal person sees a letter. So 6/6 means that the patient standing at 6 meters can see all the 6/6 letters. Each Snellen's chart has 5 segments. So how to calculate is based on the concept of MAR, minimal angle of resolution. Each segment subtends just reverse a visual acuity. So 6/6 letter subtends 1 minute, but the totality, each letter has 5 segments. So if you want to calculate the total letter subtended, the answer has to be 1 into 5, that is 5 minutes. But the patient was standing at 6 meters, that's why the answer is here is 5 minutes, and that was a relatively easy question if you have done Snellen's chart well. If you remember that I also teach in the class that if the patient stands at 60 meters, what will happen? Here the numerator will change. For example, if this question was that the angle subtended by 6/6 letter when the patient is standing at 60 meters, so his numerator visual acuity is 60/6. Minimal angle of resolution will become 6/60. Just reverse. That is 1/10. And the total letter will subtend 1/10 into 5. That is about 0.5 minute in that question. But here the question was 6 meters, so answer is 5 minutes. I always give this question in the class. If the patient is standing at 60 meters, how to calculate if the topmost letter can be seen with the patient. So here the visual acuity becomes 60/60. MAR is 1 minute and the total angle subtended will be here also 5 minutes. But here see the difference. Here the patient is seeing 6/6 letter from 6 meters. Here it is seeing 6/60 from 60 meters. Who is a normal person? Both are normal persons. So 5 minutes is the answer of the first question. A doable question. Second, glaucoma question. A very important glaucoma topic. Many questions were there in the glaucoma topic from this exam. The optic nerve head changes. In glaucoma, for definition of glaucoma, there has to be optic nerve head change. And the cup-disc ratio is not very important. I always say in glaucoma the definition is ganglion cell loss. So the nerve fiber axons which make the neuroretinal rim loss. So this cup will increase. So this is cup-disc ratio is increased and more than 0.7 is abnormal. That is a glaucoma change. Then the nasal fibers of the retina are the most resistant. The nasal ganglionic cells, nerve fibers are the most resistant. That's why the vessels are attracted towards their side. That is known as nasalization of vessels. And the vessels bend and come out of the optic cup. That is known as bayoneting sign. Roinet's nasal step is also a change in glaucoma, but that is not an optic nerve head change. It is a visual field. It is a visual field change. So that was the answer of this question. That what is not an optic nerve head change, Roinet's nasal step is actually a visual field change of glaucoma. Third question, which of the following is seen in optic neuritis? The first sign of any optic nerve disorder, whether it's a glaucoma, optic nerve compression, optic neuritis, is Marcus gun pupil or relative afferent pupillary defect. But it is not seen in multiple myeloma. Optic neuritis is seen in multiple sclerosis. And in multiple sclerosis, you do MRI, you don't do CT scan, and you give IV steroids initially for 3 days, followed by oral for 11 days. Seen in multiple sclerosis, not in multiple myeloma. So that was a relatively easy question. If you have understood optic neuritis, if you know what is RAPD, first sign of optic nerve compression neuritis is RAPD. That is Marcus gun people. Now keratoconus is always a important topic. In keratoconus, which sign is not seen? H for HAB, H for horizontal striae seen in congenital glaucoma. Famous signs of keratoconus. A young male with frequent use of glasses with famous signs. Flecher's ring, astigmatism, Maddox. Munson sign was there in the question. Munson sign is when the patient looks down, the lower eyelid bulge. Scissoring reflex seen on retinoscopy because of astigmatism, bi-oblique astigmatism. Later on it will become irregular astigmatism. A is astigmatism. V, I always say U, consider U as V. V for vertical, V for walked stria. 2 stria in ophthalmology. V for walked in keratoconus. H for HAB in congenital glaucoma. So that's the answer. It is not seen in keratoconus. Now pregnancy presents with retroorbital pain. Just see the symptoms. Pulsatile proptosis. Pulsatile proptosis means there should be a communication with the artery. With diplopia means some nerves are involved which is causing restriction of or paralysis of the eyeball movements. Tinnitus in one eye. IOP, fundus, BP were normal. Which structures are involved? If it is a pulsatile proptosis, in pulsatile proptosis with diplopia, with retroorbital pain, means pulsatile proptosis, there has to be something related to artery. Just behind the orbit there is a sinus, that is cavernous sinus. There is an artery going ICA. If there is a fistula between the ICA and the carotid sinus, that is keratico-cavernous fistula, that is causing pulsatile proptosis leading to cavernous sinus syndrome. I always say please remember the multiple cranial nerves involved in SOF syndrome, orbital apex syndrome, cavernous sinus syndrome. So nerves involved are 3, 4, V1, V2, 6. 3, 4, 6 will cause ophthalmoplegia, diplopia, pulsatile proptosis because of ICA involvement, and of course cavernous sinus is already involved. So all were involved. Maybe it was a multiple choice question. All were involved. In cavernous sinus 3, 4, 6 nerves are involved. V1, V2. So there is loss of sensation of cornea because of V1, loss of sensation of cheeks because of V2. Sometimes there can be Horner syndrome also because postganglionic sympathetic fibers also pass through ICA. That is in the cavernous sinus. See 3, 4, 6, V1, V2. That is ICA cavernous sinus. Already discussed in the class many times. The syndromes, this clinical implication of syndromes in the orbit is a very important topic. Now image based question. A slit lamp picture, a diffuse slit lamp picture was given to you. A fisherman with a history of trauma with fishtail. I always say farmer with history of trauma with vegetable matter. Fungal ulcer. This was also fungal ulcer. What is there? This sign, this sign, this sign is what? Hypopion. A very easy question. That is pus in the anterior chamber going down. That is hypopion. And in fungus, it is non-sterile hypopion because fungus can penetrate the cornea. That's why in fungus it is a non-sterile and fixed. Fixed means high fibrin content. The patient moves, it will remain in this position. It is a fixed hypopion. Hyphema is bleeding of anterior chamber. That is not. If it is red, then it is a bleeding of anterior chamber. Flare and KPs are seen in uveitis. Topical atropine is not used. This topical atropine is precipitating acute congestive glaucoma. Actually now the name is acute angle closure. Now they don't say acute congestive glaucoma in the class always, because in acute angle closure there is no optic disc and visual field change in an acute stage. That's why now it is known as acute angle closure. So maybe in the exam they give an acute angle closure or acute congestive glaucoma. That was the answer, because in angle closure patient, mydriatics, that is anticlinergic actions, having anticlinergics having mydriatic action or mydriatic like atropine, which is a mydriatic cycloplegic, precipitates angle closure glaucoma due to pupil block mechanism, iris Bombay. In myalgic glaucoma, topical atropine is given because it deepens the anterior chamber. It is because it is a secondary glaucoma, not a primary glaucoma. In anterior because of ciliary body spasm, in corneal ulcer ciliary body spasm, topical cycloplegics are the adjuvant treatment of choice. So in myalgic glaucoma, it is given to deepen the anterior chamber, while in C and D it is adjuvant treatment of choice to decrease the pain, decrease ciliary body spasm. But it is not given in acute congestive glaucoma. Now there was a controversy over here. Many people say that the question was most common cause of blindness in India. Some says most common cause of moderate to severe vision impairment. So these words are very important because the answer will change. So what is the blindness? answer is untreated cataract. If it is a visual impairment, answer is refractive error. So I don't know which was there in the exam. You are the best judge for yourself. You can see whatever is the answer according to what was asked in your exam. Okay, this oculocephalic reflex. I always explain this in the squint topic. Vestibulo-ocular reflex, Doll's eye reflex. When we look up, the eyeball goes down. When we move your face towards the right side to maintain the body balance, the eyeball goes to the left. Passively go to the left. Why? Because there is a fluid in the semicircular canals in the ear, which send impulse to the eye to maintain the body balance. So for example, if your head is shifted towards the right side, to maintain the body balance, the eyeball shift to the left side so that the body does not fall. So which nerves are implicated? Slightly difficult question, but still if you have attended class, you could have answered. It is a mechanism involving the 8th nerve in the eyes, the 3rd nerve and the 6th nerve. So 3, 6 and 8 are involved. If the question was which is not involved, the answer is 4th. Or if the question was multiple choice, answer is 3, 6, 8. That's the Doll's eye or the oculocephalic reflex. In the squint, it is used for the compensations of the squint, which I always explain in the class and give you a simple mechanism as well later on. The complicated cataract means any intraocular pathology. See, direct question. See, any intraocular pathology like uveitis causes change, or tumors or any degeneration in the eye is causing complicated cataract. So it is after uveitis. Yes, that is correct. It is polychromatic luster. It is breadcrumb appearance. So directly it is coming. Krugenberg spindles, it's seen in pigmentary glaucoma. It is pigments on the posterior surface of the cornea. So that's the answer over here. That is not seen in complicated cataract. That is a feature of pigmentary glaucoma. That is a secondary open angle glaucoma. Pigments on the iris are losing, and because of reverse, I hope you remember this, because of reverse iris configuration. This is the normal iris configuration. This is a reverse iris configuration. Sometimes in young male scenario, after exercise with very high pressures. After exercise with very high pressures, because iris and zonules are close together, they rub. So pigments are released all over the eye. They block the meshwork, pigmentary meshwork to background meshwork pigmentation, causing secondary open angle glaucoma. Pigments are seen posterior to the endothelium. That is the Krugenberg spindles, and iris is losing the pigment. So iris trans illumination defects are seen. This is pigmentary glaucoma, secondary open angle glaucoma, but complicated cataract does not have Krugenberg spindles. So there's a match of the following questions. It was a relatively easy option because many students have told that color vision directly. Only one of the option was there, Ishihara with color vision. That it's a subjective test for color vision, color sense. That is Ishihara. That is an easy one. Intraocular pressure, you should know intraocular pressure is tonometry. The gold standard is Goldman Appalachian tonometry. You should know this also, that perimetry, peripheral vision, visual field is by perimetry. And nobody gave me a correct question which was on the exam. Some says transverse slit, some says slit lamp. So only one of the option was with color vision and Ishihara. That was the option. That was an easy question. But central vision, slit lamp, biomicroscopy is a gold standard. Maybe that was in the exam. I don't know. I can't. Nobody could tell correctly the recall over here. But the other three were very simple. Visual field, perimetry, intraocular pressure, Goldman is a gold standard, while color vision is Ishihara. You know which one is a subjective test? Ishihara is subjective test. Goldman is an objective test. Perimetry is subjective test. Slit lamp, biomicroscopy, if that was in the question, that is an objective test. Now, see a direct question from one of the TNDs. A patient with icterus in the eye, maybe jaundice, patient with jaundice, patient with ataxia, akinetic rigidity, elevated liver enzymes, dementia, means basal ganglia, liver and eyes are having some problem. Answer is nothing but Wilson's disease. Okay, so Wilson's disease is, there is a increased copper in the eye, cases, Fletcher's ring can be there, sunflower cataract can be there. Gonioscopy is an early investigation because copper is deposited in Descemet's membrane, and termination of Descemet is known as Schwalbe's line. That is the first structure seen on gonioscopy. Corneal findings can be used for monitoring therapy. Why? Because if you treat Wilson's by chelating agents like penicillamine, the K-stress ring reverses. So it's a good prognostic factor for treatment. And layer involved in the Desmond membrane that is there in the posterior cornea, but it is not pathognomonic for Wilson's because cases stretches can be seen in other conditions as well, cirrhosis, chalcosis, intraocular copper. So here in my T&D answer was A, but here in your exam the answer was also A, that is Wilson's disease. Basal ganglia, liver and eyes are involved in Wilson's disease. Now this is a repeat question, but took in the class as well. What's the most common ocular manifestation in COVID is a virus, and virus, that's the infection. Mostly follicular conjunctivitis is seen. So acute follicular conjunctivitis is the most common manifestation of COVID in the eyes. Papillary conjunctivitis is mostly seen in allergy conditions. Mucormycosis is seen as a complication of the treatment of COVID, like if you give steroids or a patient is immunocompromised, diabetes, taking oxygen therapy or steroids, then mucormycosis. That's the most common fungus causing orbital cellulitis, but it is as a complication of COVID-19, but not directly eye manifestation of COVID. Mucormycosis is mostly seen in immunocompromised patients, like taking steroids, diabetes, and oxygen therapy. Uveitis can be seen in COVID, but the most common is acute follicular conjunctivitis. That was an easy and a straightforward question. Now another picture was shown to you. This is a slit lamp picture, a diffuse slit lamp picture. This is a very easy question to identify. It's a pterygium, and pterygium is a elastotic degeneration. On histopathology, there is an elastotic degeneration that is there in the one of the options as well. It can have a head, neck and body, which also was there in the question. It's of two types. It can be, yes, it can be progressive, it can be regressive. It can progress onto the cornea at the level of Bowman's membrane, and if you just excise it, that is with base sclera technique, there is 70% chance of recurrence. Here the option was simple excision will reduce the recurrence by 95. So that's the incorrect statement. The incorrect statement means C is the answer, because you have to give the incorrect statement, or which is the false over here. So C is false, because the best treatment is excision with autoconjunctival transplantation. Only excision with base sclera will give you 70-80% chance of recurrences. Okay, so that is not C is not a correct statement over here. So pterygium is an easy topic, but many questions are asked in this. Which astigmatism it can cause? It grows in the horizontal axis. So if it grows in horizontal axis, it makes the horizontal axis flat. In comparison, the vertical will become steep. Who knows vertical steep means which rule? With the rule astigmatism initially. That is the most common cause of vision loss in pterygium. Later on, it can cause irregular astigmatism as well, like in keratoconus, because it changes the corneal surface irregularly later on. Now, a direct question to identify. It is not symblepharon. See, one of the direct pictures. See, additions between the upper and the lower eyelid is ankyloblepharon. Trichiasis is misdirection of eyelashes inside, touching the cornea. Entropin is totally internal. The eyelid margin is turned inside. So ankyloblepharon is formed due to failure of the two eyelids are always in the class. Two eyelids fuse and then they separate. Partial failure of separation is known as ankyloblepharon. If they totally do not separate, that is known as cryptophthalmos, where the entire skin is covering the eyeball. Here partial failure of closure is ankyloblepharon, that is causing adhesions between the upper and the lower eyelid. The pharmac and ophthal question you can consider as a pharmac question or ophthal. Drugs which glaucoma is a very important topic. So many questions in glaucoma, 4 to 5. Drugs which increase the trabecular outflow. So increasing trabecular outflow is by myotics. Alright, myotics was not in the question. Acetazolamide decreases secretion, timolol decreases secretion, brimonidine decreases secretion and increases uvascular outflow as well. It is not increasing the conventional outflow. Conventional outflow is increased by a new drug. I always, when I gave this video in the eMedicoz app, nitazoxanide has a triple action. It increases the trabecular outflow, it reduces the production also, it decreases the episcleral venous pressure also. So this nitazoxanide was the answer over here, which is increasing the trabecular outflow. Now some students told me that there was another question on dorzolamide. Maybe they couldn't recall correctly. that topical dorzolamide is a topical, or some other options is dorzolamide is a topical carbonic anhydrase inhibitor. But I think that was a separate question, but nobody gave me a correct recall. I don't know if it was there or not, but here the question was direct drug which increased vagal outflow is Rho kinase inhibitor, that is nitazoxanide. So that was 16 questions in ophthalmology. As I told you, if you have done well, you could have scored easily, I think 8 out of 8, at least not at least 7 out of 8. But if you have scored 6 also, that is also good. Alright, thank you very much. Thanks for listening. It should be a short and a concise recall of the questions, and just see the video and see where have you made mistakes and how much questions have you done correctly. You can ask me questions anytime. Thank you for listening. Best wishes.